Welcome to The Lead Climb, the podcast where we break down the strategies that drive patient acquisition and growth in behavioral health. Hosted by Growth Sherpa Consulting, we bring you expert insights on digital marketing, admissions, business development, and more, so your treatment center, mental health clinic, or private practice can thrive. Whether you're a CEO, admissions director, or marketing pro, this is where you'll find the tools to scale smarter. Follow us up the mountain. Let's lock in. All right. Welcome to this episode of the Lead Climb podcast. Today I have Christopher Wolfington with FinPay. Christopher, why don't you tell us a little bit about yourself?
So yesterday was my birthday, so let's start with that.
Happy birthday.
So another year survived. I'm most proud of the fact that I'm the father of 4 great kids. And that's the most notable thing. Really, it's the only thing that matters, in my opinion. Everything else is what we're doing while we're trying to be good parents, right? As you mentioned, I'm the founder of FinPay. My day job at FinPay is Chief Revenue and Strategy Officer. And back in 2020, we hired a real seasoned CEO, a guy named Tim Kowalski, to run the business. Which has really given me the freedom to focus on revenue growth and strategy, and which is the stuff A, I'm good at, and B, I find fun. And FinPay is my 7th startup. Little fun fact. I'm sort of an entrepreneurial junkie, startup junkie. I just love the notion of building something from nothing. Prior companies have had as many as 9,000 employees. That was probably the craziest one. We went from concept to IPO. I was with a bunch of other people involved. It wasn't just me. We did JP Morgan's first ever IPO back in 1996. So I'm showing my age a little bit there. But I've always been in businesses that have been around engaging with consumers. And so if there's one common theme between the 7 startups that I've been involved in, it'd be that. Most of them have been around consumer payments. And the current FinPay business really came about as a result of my 35 plus years experience in consumer related businesses. I ran into some scenarios in healthcare with some family members. It was just absurd to me the way the financial experience was handled in healthcare. And coming from a consumer payments background, I thought there's no way this is how the largest economy in the United States, engages consumers around cost. It turns out I was right. It was as crazy as it seemed. And so I knew there had to be a solution for it. And that's how FinPay started.
Awesome. Well, glad to have you. One of the things, I think this is actually where we've met before this, but we really started getting to know each other was about a year or so ago at a conference, and you and I were on a panel together. And you, for the first time, brought up something that I think probably should have been common sense for me, and it never really hit. So I'm assuming for the people listening is probably very similar. It was the role and depth and breadth of compliance and patient responsibility for their collections, for their part of a payment for treatment. I think that there's a misconception in this industry where if you send them 3 letters or you text them twice or all the crazy stuff that I've heard about, if you do these 3 things, it'll mean you're meeting needs of compliance. Can you talk a little bit about that? Because I think from all the guests we have on, the conversations usually lead to compliance in one way. So I kind of want to kick today off with compliance because that one has always struck me as a topic that isn't discussed nearly as much as it should be and is wildly important for treatment center owners to understand.
So the first way to start about it is realize that whether it's fair or not, it's another debate on another day. But behavioral health, specifically SUD, has multiple compliance requirements as it relates to how they engage the patient around cost. So number one is what every business has, and that's consumer protection laws, right? So it doesn't matter if you're a big bank, if you're a credit card company, if you're a healthcare provider, if you're engaging with patients, taking payments from consumers, you have to comply with consumer protection laws. This is something that's most commonly overlooked in healthcare. And part of the reason is because for a long time, nobody cared if the patient paid what they owed. right? The revenue model in prior years, I'm saying prior meaning 5 years or longer, was, hey, look, the reimbursements are strong enough. In the SUD space, the out-of-network model was dominant in the beginning, and the reimbursements were so high. Why would you ever alienate a patient or potentially lose a high revenue admission by talking to a patient or a family about money? Just wink, wink, come on in, don't worry about it. And to be fair to the providers, like, it's reasonable they didn't care because the payer didn't care, right? And so if the payer doesn't care, why should I, as the provider, care? And then the domino effect was, well, then the patient's not going to care. And the patient gets in the habit of not having to worry about this money. Oh, the bill came in the mail, just throw it away. The last domino to fall was the technology providers didn't care. So you have CRMs and EMRs and revenue cycle technology that provides no functionality whatsoever around patient financial responsibility, anything to help be more intelligent and transparent about how you engage patients about cost. And so it was like the perfect negative storm. Payer doesn't care, provider doesn't care, patient doesn't care, technology providers don't care. And all that was great until 2018. And in 2018, the Elimination and Kickbacks and Recovery Act, which is commonly referred to as ECRA, was a federal law passed that said, if you're in the SUD business, it is now a criminal offense, criminal, go to jail, for waiving or reducing out-of-pocket costs, even for commercially insured patients. So I want to make it very clear, CMS for Medicaid and Medicare patients have always had that rule, right? CMS is a way to prevent fraud, and inducement has always had a rule that says you're not allowed to reward patients to induce them to come get healthcare services through you. That's why healthcare is one of the few industries that doesn't have a rewards program. Right? I bet most people never even thought of that. Hey, that's right. Like,
No punch card.
right? I get no free gift cards. I get no, and the reason is because it's specifically, you're not allowed to give any type of inducement, rewards or otherwise, for someone to get their healthcare services through, your specific medical practice. So in 2018, the federal government expanded that to include commercially insured patients, right? So what that means is that, and think about this if you're the provider. If the payer hasn't cared, I haven't cared, the technology vendors haven't cared, that means I don't have any subject matter experts that work for me. I never hired someone to be my patient financial management VP or director, because why would I spend money on a part of my business I don't care about? What's really interesting is it's sort of a really double negative. So at the same time, you had this heightened compliance requirement put on the provider, coincidentally, was right in the middle of this reimbursement rate compression, I'll call it, right? And the best analogy that I could probably give you, and I show this to people all the time, look on your screen and you compare what an admission was worth in 2013 and what portion of that revenue was due by the patient. It was less than, roughly 2%. Since
And so
then,
for if you're listening on Spotify real quick, just so everyone knows, in 2013, the patient financial responsibility is at 2.3. Now 25.6. That's 10x. That's pretty significant.
yeah,
That isn't
and
good.
now that's not unique to substance abuse, right? Like all throughout healthcare, when the Affordable Care Act, sometimes referred to as Obamacare, was passed, it really was the first time you started to see these high deductible health plans come into the market. And then to employers started to offer multiple plan choices for their employees. And, let's think about it logically. You're an employee, you're signing up for a health plan, and one of the plans takes out $500 a month out of your paycheck, and the other one only takes $200 out of your paycheck. Like, I don't know, simple math says do I want to spend 500 bucks that maybe I'm going to need to use my insurance and that higher deductible applies, as opposed to they're definitely taking $500 out of my paycheck. And so you saw this explosion using this strategy. This is how employers saved healthcare costs, because they let the employee decide which plan they wanted. And think about it. Most people are going to say, so my choice is $500 out of my paycheck or 200. I'm picking 200. Not realizing that meant when they go to use their insurance, instead of maybe owing $1,000 for whatever care they got, now they owe $4,000 for that same exact care.
Yeah, and a lot of people, I know myself included, we're fine with that that sort of mindset, unless we know we have a surgery or a birth or something that could cost a lot of money that year coming up. But for people for substance use treatment, along the way, it's usually not that thought process like, you know what, this November I'm gonna go to treatment and need to spend 30 or $40,000, right? It's that friend of mine, $200, it is what it is, and then boom, oh, that decision was not the right decision because now we're in crisis.
So now take that a step further to get back to your original question that I'm long-winded answering. Compliance. So now our rates are coming down as the out-of-network model continues to be under attack by rates coming down and payer audits increasing on a alarming level. I personally have sat in twice as many payer audits in 2024 as I did in 2023. Literally, it was actually more than twice as many. So now my consequences of not collecting this money are potential criminal, consequences. But the more practical exposure for waiving or reducing these costs is payer audits, where a payer comes in, audits you, and says, "Oh, by the way, you've induced patients because you can't prove to me that you have standard operating procedures around patient financial management. You can't show me your 3 regular and customary collection efforts, and show me where your good faith estimates are. And when you show up with spreadsheets and paper to substantiate the answers to those 3 questions, it really puts you in a position where you're going to lose that audit, and therefore is a basis by which they may claw back claims." And that's the more practical risk exposure, right? Don't get me wrong. If you're referred to, mostly it's from the payers, right? The payers refer to the Justice Department, a particular provider. There was a huge Aetna lawsuit in the end of 23 for $250 million, trying to claw back 5 years of claims. Inside that lawsuit was, of the 6 complaints inside the lawsuit, 4 of the 6 complaints were around inducement. The other 2 were around some bad marketing practices, body brokering, the normal bad actor stuff. But it tells you how the payers think, right? They're going after where they assume that you stink. And the myth in the business, to really answer your question originally, is sending 3 statements does not count as a regular and customary collection effort. And I'm using those words very specifically. Regular and customary collection effort is the actual language in the statute and is statutorily defined. What counts? So a phone conversation, a face-to-face conversation, a text message, email efforts. Simply sending someone a statement of services rendered does not count on its own as a collection effort. So you can send out 3 statements. Good for you. I'm happy for you. But that's not meeting any of the compliance requirements in this area of the business that would expose you to those both payer audits and regulatory enforcement. But more practically, Steve, because compliance always happens to the other guy, right? And FinPay, I said, it's my 7th startup. I'd be lying if I didn't say, historically, when you're building a business and you're trying to scale it and grow it, someone comes to you and says, "Oh, we got to spend all this money over here for compliance and for something that might happen," right? It's really tempting when you're really growing and you're trying to meet the financial demands of growing a business to invest in a part of your business for something that might happen, right? Um, and right, you see it with HIPAA compliance, right? You see it with other areas in healthcare compliance. But here's the real reason, in my opinion, that this is a big issue. the rates have come down significantly. So with the value of an SUD admission 10 years ago was here, it was 20 grand, 22,000, even in network. If you're out of network, double that number, right? And today it's 30% less, typically. And the payers aren't stupid. One of the interesting things that people don't realize this, so I'll share it with you. The biggest impact COVID had on this industry, in my opinion, this is strictly my opinion, I don't have any quantitative data to support this, but the logic really makes sense. The payer community was so indifferent about behavioral health, and even more specifically SUD, that many of them carved out the management of the claims to third parties. Like I have Independence Blue Cross in Philly. For as long as I can remember, Independence Blue Cross carved out to Magellan the management of their, behavioral health claims. And so did a lot of other payers in a lot of different states, a lot of different markets. And because if you're the CEO of a Blue Cross payer or United or Aetna or whoever, you look at behavioral health claims as a percentage of your overall business that you do, and it's this small single-digit percentage. And you're like, let's be honest. Isn't it reasonable for that person to be like, well, who cares? Like, let Magellan have that. I'm going to focus on this other stuff. So now COVID comes along. And all over the media, I don't know if you remember this, Steve, but you couldn't turn on the radio or the TV where somebody wasn't talking about the behavioral health consequences to everybody, including children, on the lockups and COVID and what it meant to everyone's mental well-being and suicide rates and drug and alcohol abuse, yada, yada, yada. So you know who else was hearing those messages? Was the CEOs and the C-suite of all these payers. And if you hear someone on the news over and over and over again telling you that there's a 3 to 7 year tail of the mental health consequences in behavioral health, meaning if COVID ends in 2022, that means it's 2029 that they're still going to have residual impact of mental and behavioral health in the United States. So if you're that C-suite of that payer, you're saying to yourself, holy crap, I better get ahead of the curve. Let's get Joe or Mary into my office, whoever it is that's in charge of that. Joe and Mary, get in here. Tell me what's going on in our behavioral health business. And Joe and Mary go, well, we don't handle that. You decided to carve that out to Magellan. It's like, well, okay, well, get someone from Magellan in here. And Magellan comes in, and all of a sudden this CEO finds out, wait a minute, we're paying $3,000 a day for resident. Wait, what? Wait, we're paying $4,000 a day for detox? Wait, who the hell approved that? And now all of a sudden this huge spotlight gets put on the business. Now, if you're the payer, let's just be honest. They're not an insurance company. Everybody calls them insurance companies. They're arbitrage companies. And their arbitrage is, I always have to make sure my claims paid is less than my premiums in. Right? As long as my premiums that are coming in the door are more than my claims going out the door, my arbitrage, my profit's the difference. So all of a sudden,
Well, even more so than that, they're very big into the investments, right? So taking that delta of claims in versus payouts out and investing into the market. So for this year, my larger concern for the smaller programs that we work with is there's market volatility, payers don't want to pay because they want to be able to maximize the lows for buys and sell on the highs and go from there. So I think that's for me, I think that's the other part of the payer concern that we have right now. For the rest of this year in particular is the uncertainty.
now take that logic. So now this is I said I don't have any quantitative data to support my theory, but let's take exactly what you just said. What you just discussed, and is very true, is evidenced by the attack on the out-of-network model. Because the best way to put that pressure on the provider community, like you just articulated, is to force you to go in network. And if you're in network, I have a managed care agreement with you. And that managed care agreement has very specific guidelines and rules about when I do and when I do not pay you. for claims that you submit to me, not even as granular as the details in which the claim has to be submitted and what needs to be included in it. So I've empowered myself as the payer to inflict a level of influence on you, the provider, on what I am and am not willing to pay based on those highs and lows that you just referenced. So that, so now that makes sense in that context. It makes all the sense in the world why the payer community is attacking the out of network model. And here's the other evidence that I'd love your opinion on. If I simply would just didn't want to pay you more, if my goal as a payer was I don't want to pay $4,000 a day, I would simply pay you less all the time, right? I'm only paying you $400 a day. I'm making that number up. The problem with that is the provider can adjust both in staffing and other things. But what the payer community is doing is they're not paying consistently low. They're, I believe, purposely paying high on some claims, low on other claims, high on some claims, low on other claims. And what does that do to you as the provider? The thing I can't handle, the thing I can't tolerate running a business, especially a treatment facility, is the unpredictability of my revenue stream. And if I have a payer mix and a patient population where I have no clue what my revenue is going to be, how can I possibly build an infrastructure and a staffing model that allows me to provide quality care and make a profit so I have a sustainable business? So to me, the biggest evidence that everything what you just said and what I said is the fluctuating rates that they pay on the out-of-network model, the heavy push to force people to go in network. And once I have you in network, the good news is I'm selling you on the notion that, oh, you're going to get more patients because I have I as a payer have a dominant position in your market. So you're going to get more patients, even though I'm paying you less, and it's more predictable revenue. You know what you're going to get. But what comes along with that is a whole lot of compliance. And
Well, and sorry to cut you off on that. I think the challenge with that too is, and now that that payer has 6, 7, 8 in network, same level of care, same billing code programs that in that same market, the promise that you used to get with going to network was you'll get our referrals for your treatment. It's not happening anymore. There's many programs I work with are in network with lots of payers, and they don't get a single phone call. And that's unfortunate, obviously, for them. But the second part is, and this is actually on another conversation I had that will also be on our pod either right before or right after this one, is the diversification of revenue streams for treatment centers is paramount, given what you just said. There is that unpredictability that then compounds with seasonality and then compounds with the competition increases that are going to these markets, that compounds with increase the cost of goods sold, increase the labor due to inflation. So you can either continue to take your contracted payments that are varying or late or slow or fast or high or low that you have really no control over. And you can sit there and take it, or you can do something about it, which is diversifying revenue streams, increasing the length of engagement with clients, improving patient financial responsibility. There's a lot of different ways of approaching that, but doing nothing is not a strategy. And that's far too often what we're seeing, even from a lot of the big organizations that we tend to do some work with, is the doing nothing or the status quo strategy. And that's a concern to me because it's not like we're having a shortage of patients who need our help, but we are having a shortage of proactive treatment centers who are saying, let's understand what this looks like. It won't get voluntarily better. How do we mitigate this and still continue to provide great patient care? Because to your point, something's got to give. You can have a worse facility if you need to cut costs. You can have worse food. You can have lower level employment. You have less employment, which means higher turnover, which ends up costing you more anyway. Something has to give in the budget of a treatment center, unless you're it's all cash pay and it's 6 figures a month, and then that's a whole different conversation. But if you're relying on payers, either you have to diversify your revenue streams, create a longer tail, improve patient responsibility. There's a handful of things you can do, or you have to make a cut that's uncomfortable. And I don't think that's the best idea for the patient, because I personally believe that patients should enter recovery feeling is punitive, and sometimes that's what those cuts can do.
And the biggest, and this is my opinion,
Mhm.
the biggest challenge is if you ran an out of network model for a long time, and I'm not picking on the CEOs of these companies, but many of them were able to make money despite themselves. In other words, there wasn't this innate pressure, the old adage that necessity is the mother of invention. There wasn't a requirement to have very efficient workflows and processes and automation inside a business, right? You could still make a really good margin. What you just said, and also as rates are coming down, as you know, Google is getting more, let's just call it interesting in how they're bidding for the pay-per-click and the positioning on the searches is going. So CPAs are going up. I mean, tell me what could be worse for a business model when your gross revenue rates are coming down at the same time your CPA and cost per admission are going up. I mean, what's going to happen is, and I'll quote one of my customers, it's a really smart guy, Rob Harrison. He's a COO and one of the owners of Recovery Unplugged. And he says the only, the future is the companies that are going to survive and thrive are the ones that are able to have a care delivery model that has the lowest cost care delivery model without sacrificing the quality of the care. And the only way to really do that is literally to search out ways to automate everything that you can so that you can become more efficient, including in your staffing model, so that you're spending your money where the care is and less on manual tasks. And then as part of that, it also, if someone agrees with my point and what Rob thinks, I happen to subscribe to what he thinks, by the way, for what that's worth. I personally believe that I think quality of census should always have been everybody's goal, but now you're going to be forced to be focused on quality. And what I mean by quality of census is pick programs you can deliver very efficiently in a cost-efficient basis at a high quality, and then have a good balanced lead gen strategy, right? Outreach, biz dev, digital, right? Have some balance, understand your market so you know what that balance should be, right? It's not accurate to say, well, California should be, 20% digital and, 25, whatever the math is. The market really dictates what that is based on the demographic of the market. But once you figure that stuff out, then it's a question of sort of what I do is the patient financial responsibility, this thing that nobody cared about forever. Well, guess what? This thing that nobody cared about forever now can make the difference between you making money and not making money. If the patient owes 20% of all your revenue, and in an in-network model, that's a fact. Well, I don't know how many businesses that you know of that can have 20% of their revenue not pay them
Right.
and still be a sustainable business. And the challenge to most operators is they manage from the bookends, right? What do I know? I know how many admissions I did last month, and I know once my claims have adjudicated what I got paid. Well, there's a whole lot of stuff that happens in between those two time periods. I mean, a whole lot of stuff. And so our logic at FinPay was, well, if it's 20% of your revenue, the first step to getting paid what you're owed is knowing what you're owed. So we built a one-of-a-kind estimator tool that is meant so the admissions team can say, what is this patient going to owe? So then I can balance between, all right, if I think this admission is worth $15,000, how much is coming from insurance? How much is coming from the patient? And if a significant portion is coming from the patient, I better collect some of it now. Like, right? Like it's
Yeah,
just common sense.
yeah,
But there's been no visibility in the past. That's
and so
FinPay.
let's talk a little. So let's talk a little bit more. That we're running out of time on this one, and I'd love to have you back to continue these talks. These are dense talks. There's a lot of information on patient financial responsibility. But the one thing I did want to make sure we addressed is so here. What I love about this industry is people are truly passionate, and generally speaking, the extreme majority of people who run treatment centers really care about the patient outcome. I worked in general surgery prior to coming to behavioral health, and I can't say everyone truly was super passionate about hernia repair. It was like No one ever asked me, like,
I,
why are you
I
so
I can tell you, I'm not passionate about hernia repair.
No, I was passionate about my 3 hernia surgeries, but but other than that, you know, when I worked in it, no one ever asked me like, "Why are you doing this? Did you have a hernia? Does a relative have a hernia?" Like, no, no, people just did their job. It was what it was. But here, people care, right? It matters, and for better or for worse, that leads to a lot of people with a high level of passion, but probably a lower than general for a healthcare company level of business acumen coming into a role of an executive in treatment center. Sometimes, like you said earlier, they were successful kind of, without getting their own way or despite themselves, they were successful. So here's what I'm getting at is the biggest push I've gotten over the last decade and change of doing this line of work is if I ask the patient to pay me, they're going to relapse. There's this underlying, I would say, self-fulfilling prophecy, lie we tell ourselves, misnomer that a normal business practice that is very common from your dentist to your optometrist to a hernia surgery. In this one specific case, if it's for treatment, it could lead to negative outcomes. Can you talk on that for a little bit?
So first, the best way to dispel, in my opinion, that crazy thinking is, so I'm going to ask some rhetorical questions, but feel free to answer it. What's the goal? If I'm a treatment facility and I have a patient come in the door, what's my goal for that patient? What's the ultimate goal?
Recovery.
Recovery. They stay sober. So we already talked about that you have the obligation to collect these out-of-pocket costs. And we've talked about the myth that people send 3 statements just because they think that makes them compliant, which it doesn't. But that's not the point here. So my goal is to help you get sober and stay in recovery. So here's my strategy. I'm going to let you enter treatment. I'm not going to talk to you about cost. I might mention your deductible. In fact, I might even try to collect a deductible, which is even worse than doing nothing. And I'll explain that in a second. And all of a sudden, I go through my 30 days, 20 days, whatever it is. And I get home, and 60 days later, a $4,500 bill shows up in my mailbox. And then it shows up 3 months in a row. Now, would you argue with the fact that financial stress is one of the top 3 leading causes of relapse? Would you debate me on that? Right? You would
Okay,
not debate. You would not debate. Nobody would. So here's the model. I'm in the treatment business, and I have a business practice that specifically is triggering one of the most common causes of relapse within 90 days of when I treated the patient. That
which,
is the
as
most absurd thing. Now let me go one step further.
I was gonna say, that time period in particular also is where you see the outcome studies start to dip, right? That 90-day is that dip.
So let me take it a step further. So I'm in the treatment business, which means I want to provide treatment. So normally a patient that goes through my facility, assuming my care is good, my facility is nice, my food is high quality, right? The clinical experience was awesome. How would you feel if a bill showed up in your mailbox for 3 to 4 grand that nobody ever told you about, nobody ever helped you with? In fact, and this is what I meant about even worse. When I spoke to them, they said my deductible was $1,000. Maybe I even paid them that 1,000. So I actually thought I was done because you told me my deductible was 1,000. I paid it. You didn't tell me about coinsurance. You didn't tell me about copays. You didn't tell me about this other stuff. Now this $2,500, $4,000 bill shows up. If I relapse, I don't know where I'm going. I only know where I'm not going.
Mhm.
I'm not going back to you. And not only that, if I have a friend or family member that needs care, there's no better brand ambassador in the world than a happy alumni. None.
And let me tell you about that. So my former doctor, my former primary care physician, sent me a bill years ago at this point, 18 months after a service for $25.36. Clearly, this left an impression on me. I can absolutely pay a $25 bill, but it was the audacity to send this bill 18 months after saying, hey, you got to pay us this money, or we'll ding your credit if you don't pay it. out of nowhere with no explanation that said, you know what, I'm done with this practice. If you can't have that conversation with me, you can't have a well-run practice. I don't trust you have a well-run clinical medical product, right? So for me personally, that happened on such a small scale. I can only imagine from the patient standpoint to you're saying, I'm done. I'm not going back if $4,000, $5,000 hits my mailbox and I'm expected to pay it and is never brought up. And you can't tell me
Well,
why
not
it
only
wasn't.
that, think of the stress.
Yeah.
Someone's 30, 60, 90 days out of treatment, probably maybe not even back into an employment scenario yet. Or if they are, they're recently back in. And a statement shows up. Now, remember, the provider just wants to be compliant. There's not even follow up on the statement. They're not even, oh, let me help you with this. Let me answer any questions. No, figure it out on your own. Like, that is so absurd to me. So, and here's the irony. So we did a study. We were at about 200,000 patients on our platform. So and about $500 million of patient financial responsibility risk that we've managed. And we wanted to know, to dispel that myth about if I talk about money, they'll relapse. Or the more common one is, Steve, is if I talk about money, they'll go to the competitor down the street, right? And by the way, 10 years ago, without a network with the huge
100%.
$20,000 maybe you could, you know, uh, show me there's that.
Yeah, there's definitely legacy beliefs based off of that time period for
But
sure.
here's our data. Patients that were engaged prior to admission, and we had 200,000 patients of data. Ready for this math? They paid 76% of what they were owed, what they owed. The industry average today is 13 to 15% collection rate. So you have 20% of your revenue that you only collect 13% of. Patients that were engaged prior to admission paid 76% of what they owed. Their patient satisfaction score was 97.2 when the process was done right. Right. And that's one of the things our software does is empower the employee at the treatment facility to be more intelligent and transparent and upfront and empathetic about how they discuss cost. And so the satisfaction scores show that. And the average length of stay for inpatient was 3 days longer, and outpatient was 5.1 sessions longer. And here's the logic. I couldn't quantify why, but it makes sense. If I go into treatment with any concerns about cost in the rearview mirror, because I was helped, somebody helped me work through that, why would I leave early? Usually it's the fear and anxiety, concern about cost that, and patients in 2025, families, they know they owe money. Just because you don't bring it up doesn't mean they don't know. It's this big pink elephant, this big gray cloud that follows them through treatment. And the reality is, look at AMA rates, right? Most AMAs are financially related, not just clinically related, right? And so it's complex. This is why electronic financial records are so important. 90 some odd percent of the treatment facilities do not have electronic financial records. Think about what the world would be like if EMRs, EHRs didn't exist. If people were still using paper and spreadsheets to manage clinical charts and getting claims paid, it'd be a nightmare. Yet here's 20% of their revenue, right? That they're using paper and spreadsheets to manage across multiple departments where the admissions department doesn't know what the facility people are doing. The facility people in the back office don't talk. And there's no electronic financial record that crosses over multiple departments. Oh, my little thing there, my little love and there's just like if I go like this, it'll float up the other thing. So
I don't know. We got ours.
yeah, so the beauty of electronic financial record is it follows the patient for their duration of their experience with their treatment provider. That means pre-admission. That means during care. That means post-discharge. That means even if it's a collection conversation, right? That everybody in the organization across multiple departments can always see what's going on. The compliance is automated, right? So if you have a payer audit, you literally could flip up a laptop, show the auditor all your standard operating procedures, show them all the good faith estimates that you provided for every patient, show them the 3 regular and customary collection efforts whether or not it's mobile engagement, whether if it's a conversation, an email, whatever it might be, it's date and time stamped in the system. So, and here's the beauty of it. By simply using an electronic financial record, you become compliant, number one. And if you use it the way you need to be compliant, you'll get 70% of what you're owed paid instead of 13%. And interesting, if you handled all your payment concerns up front, what's now your last experience with your healthcare provider? Clinical. And today, for most people, the last experience is financial. The care's first, the bill's second. But if I already took care of it, and now if I relapse, or now if I have a family member or friend that needs care, I'm going to refer them back to the place that I had a great clinical experience. And if I had a great financial experience on top of it, even more so. Hey, these were the guys, I couldn't afford it. I didn't have any money. This was the place that helped me out. They made the unaffordable feel affordable. I'm referring my friend to them. And here's the test. Will you agree that the relapse rate in the United States is over 50%? Like definitely, right?
Absolutely. Absolutely.
Right. So I use 50. I agree. It's way more than that, but I'm saying 50 so nobody can debate this fact. The best test to know if your patient financial management strategy is failing you, when your census is less than 20% alumni, you know you have a problem. And here's the irony. And here's how I'm saying that. If 50% of the people you admit are relapsing, in my example, I think it's closer to 65%, but let's just say 50, and I have a good facility and I treat my patients well, why wouldn't 50% of my census be alumni?
Well, see, I appreciate this one, and it's a great one to end on too, because the one thing from Grow Sherpa is we always, for most cases, we'll say 20% is the target for that, because you do hope and you hope through outcome studies that your population is doing better, right, and not coming back. But yeah, 20 is our target, so that's spot on. Hey, Chris, I hate that we have to run out of time, but we are today, unfortunately. Let's do a second one sometime soon, though. I like this. I think we have a lot more to talk about on this one.
Yeah, I would love to continue the alumni
Yeah.
conversation. I have some
Yeah,
really
let's do that.
data around that too.
Absolutely. Well, do it here. Tell everyone how they can find you and find FinPay.
So, well, the easy way, www.finpay.com. There's an obvious one. My direct email is CW, my initials, at finpay.com. And they're the two easiest ways. If you've ever used electronic financial records, you thought of it, you need a patient financial responsibility estimator tool. You're looking for the ability to have better visibility into this part of your revenue and who's paying you and how they paying you and where and why, and you're looking to create automation. That's what we do. But like you described, I have as you could probably tell, a kind of crazy passion about this space because I think there's so much good work being done, and there's going to be some really interesting opportunities as a result of everything we discussed today with what's going on with payers and out of network and in network. And I think we're going to see a lot of change in this space. And I'm really excited to see, who are the people that are going to come out on top. I think you're going to see a big consolidation wave as the less efficient operators get kind of squeezed out of the space, because if you're not efficient, you're not going to be able to be profitable. And if you're not profitable, you won't last, right? So I love this space. I eat, breathe and sleep it all day long. So I really appreciate you taking the time to chat with me.
Awesome. Thanks so much. And if you listened or watched this entire thing, thank you. Sincerely, I appreciate that.
Yep.
Do the like and subscribe thing that I always say to do. Do the touch the buttons and share with your friends and all that good stuff. If you want to be a part of the Lead Climb podcast, ping me. I can easily be found. Chris, thanks so much. Talk to you soon, man.
Dave, you've been great, dude. Really appreciate it. Had a lot of fun.
That's a wrap for this episode of The Lead Climb. We hope you picked up some valuable insights to help optimize your patient acquisition and grow your behavioral health organization. If you found today's discussion helpful, be sure to subscribe, leave a review, and share this podcast with your network. And if you're looking for expert guidance in digital marketing, admissions, business development, or any other piece of the patient acquisition puzzle, Grow Sherpa Consulting is here to help. visit us at www.growthsherpaconsulting.com. Thanks for tuning in. We'll see you next time on The Lead Climb.